focus today on disease recurrence as a cause of long-term allograft loss. This has been proven some years ago by our Australian colleagues, showing that after 10 years, we see about 8% of all our kidney transplants are lost due to recurrence, and this was a very well-done study with a proven glomerulonephritis. And these data have been confirmed, although to a lesser extent, in data coming from the United States. You can see here an estimation of 2.6% of kidneys lost at 10 years due to recurrence of the disease, and interestingly, no effect of immunosuppression on the risk of graft loss due to recurrent glomerulonephritis. Same data coming from Canada. We see a very big difference here between those who recur their glomerulonephritis and those who do not recur and those who recur. And again, same data, no effect on individual immunosuppression or treatment here on the risk of graft loss due to this recurrent disease. I will focus today on 4 of these recurrent diseases: antiphospholipid syndrome, focal and segmental glomerulosclerosis, atypical HUS, and membranous nephropathy. The first one, antiphospholipid syndrome. I will show you some data coming from our group. We looked at patients with antiphospholipid antibodies, 2 groups, the patients with the antiphospholipid syndrome and the one with only the antibodies but not the antiphospholipid syndromes. You see lupus anticoagulant, anticardiolipin, and anti-beta-2 GP1. If we are looking at this patient, we notice that the patients with APS and antibodies have higher incidence of allograft thrombosis, higher incidence of cortical necrosis, of deep venous thrombosis post-transplantation, and severe hypertension compared to the patients in blue without these antibodies. Interestingly, when we looked at the results of transplantation in this patient, you can see that after several months, the results in terms of patient survival are not as good as the one without this antibody. If we are looking now at the biopsies of these patients at 3 months and 1 year, you can see again that all lesions, vascular lesions, arteriolar hyalinosis, CI, CT, everything is more severe in these patients with antiphospholipid antibodies. And when we are looking at their renal function, again, you see that in red, the majority of the patients are decreasing their renal function more rapidly than the patient without these antibodies. So this is really disease recurrence with a very unfortunate consequence on renal function. Is it possible to treat this entity? There are not that many data in the literature, but this paper is coming from our colleague from Geneva. They treated a patient with a lupus, and this patient recurred very quickly an antiphospholipid syndrome just after transplantation, and you see that creatinine started to go up. In spite of plasma exchange and hemodialysis, everything went badly, and the patient received eculizumab at that time, and you can see that after a while the serum creatinine decreased and remained stable, and you can see that the renal biopsy was quite good after 1 year. So this might be a new treatment of this rare entity. We have also 2 patients, and some have also been reported. Second disease, focal and segmental glomerulosclerosis. We all know that this disease has a variety of etiologies, and we will focus today on the primary focal and segmental glomerulosclerosis. We know that this recurs after transplantation, and for example, in our experience here, you can see that out of these 19 patients that were studied between 1997 and 2005, the recurrence rate was high, and with the treatment available, plasma exchange, steroids, or cyclosporine IV, we got 42% of complete remission at 3 months, and only 27 complete remission at 1 year. So only 1/4 of these patients were cured from their disease at one year. There are several pieces of evidence suggesting that there is a permeability factor in this disease. The main are that the serum from these patients increase glomerular albumin permeability in vitro, that serum from patients with post-transplant FSGS induces proteinuria in the raft, and more recently, the reimplantation of a kidney allograft with FSGS recurrent in another patient resulted in proteinuria remission. So it seems that there is a permeability factor, but we have been looking for this factor for several years, and recently, in 2011, these authors published in Nature Medicine an hypothesis. The hypothesis that this urinary plasminogen activator receptor here, which could be cleaved from the cell membrane and become soluble, this could be the FSGS permeability factor. And how could it work? This factor might be released from these cells, enter the capillary of the glomerulus here, and at this higher magnification, this SUPAR is interacting with beta-3 integrin, which is present here on the podocyte food processes, and the interaction between this SUPAR and the beta-3 integrin produces podocyte effacements and then proteinuria. This was the hypothesis. So these authors looked at the SUPAR in the serum in various categories of patients, healthy patients, and various glomerular disease, and you see that they found that in the FSGS patients, this was highly increased. And then they looked at two categories of transplant patients, those with recurrence and those without recurrence. And you can see that obviously there is here an increased level of SUPAR in the recurrent patients. Is it confirmed by other studies? Not really. You see the same group looked at 3 big cohort of patients with FSGS. You can see here these are the controls. In this first cohort, you have an increased level of SUPAR. Again, here in this other cohort, it's higher. But on the opposite, you can see here that in these studies published very few weeks ago in the Kidney International, you see that the difference is not as obvious in all these various glomerular disease. So it's a marker of something, but it might not be very specific. And indeed, there will be this paper published very soon in the pediatric nephrology asking the question, is serum SUPAR in patients with FSGS trash or treasure? When you publish this kind of paper, usually the answer is in the first word. There might be other way of looking at this problem of recurrence. This is the work we have performed in collaboration with Minnie Sarwal and the team of Leuven. We looked at patients, 10 patients without recurrence and 10 patients with recurrence, and we looked to see if there was some protein variation in these two groups. So we used the technology of protein microarray profiling, and this gives the identification of an IgG signature associated with FSGS recurrence. We then looked at this protein and to see if this protein were correlated with some genes in the kidney. We find some ELISA validation and then a new cohort to validate this data. And interestingly, it was possible to find proteins that were differing between the patients without recurrence and the patients with recurrence. And if you construct this kind of ROC curve with 3 specific proteins that were found in this study, you can see here in red that if you are composing a score with these 3 proteins, you can accurately predict FSGS recurrence with a sensitivity of 74% and a specificity of 87%. So, of course, this data needs to be validated, but this paper has been submitted for publication. That might be another way of predicting FSGS recurrence. With regard to treatment, in the past we were doing, like the other, plasma exchange, IV, cyclosporine, all steroids, but not all together. And finally, we decided a few years ago to combine these three treatments, heavy plasma exchange for at least 6 months, oral IV cyclosporine at the beginning of transplantation, and high-dose steroids. And with this treatment, indeed we got very good results, since in the last 10 patients, 9 out of 10 had complete remission at 1 year, and this complete remission is still present at 2 years. So combining all these treatments together might be a way to induce complete remissions in this patient. Another study with a new therapeutical intervention, the atypical hemolytic uremic syndrome. In transplantation, you know that having recurrence of this disease it conveys a bad prognosis. You see here in this French experience, 30% of post-transplant graft survival at 5 years in those who recur, against 70% in those who do not recur. And as a factor of recurrence, the main factor we found was the presence of a complement mutation. Interestingly, not all complement mutations have the same weight, and you can see here that, for example, the patients with the CA mutation of factor H or the mutation with a gain of function have the worst results, while the patients in whom it was impossible to find a mutation had the best results. Is it useful after transplantation, when you see recurrence, to do curative plasma therapy? Again, that's a French experience. You can see that there is no difference in between the two groups with or without plasma therapy. So now we have a new monoclonal antibody whose name is eculizumab. It's a monoclonal antibody with blocking the C5. So it's interesting because it leaves the proximal complement cascade free of intervention, and it blocks only the terminal part of this complement. So the patients are still able to get anaphylatoxin to clear their immune complex or to opsonize microbes, but the last part is inhibited. And indeed, in this paper that will be published very soon, you see that in patients with very severe atypical HUS, when you look at the change of eGFR from baseline after treatment, this is before treatment, this is during the first month after treatment, and this is during 2 years. And you can see that in these patients with a very severe recurrence, it's possible with this drug to induce a very significant improvement of renal function. Is it the same in transplantation? It is probably. This is the case report of a small girl that had early onset of atypical HUS at 6 months of age. She started peritoneal dialysis, received here a first kidney transplant with HUS recurrence, and in spite of intensive plasma therapy, she lost a kidney and returned to hemodialysis in 1995. During that time, we found a mutation in factor H and even 2 mutations in these patients, and she was treated and she received a second transplantation. And you can see that in spite plasma infusion, in spite of plasma exchange that was given prophylactically, platelets decreased and serum creatinine started to increase here. So these patients received eculizumab here, and you can see that very quickly renal function remained normal and the platelets went up. So this is one typical case of efficacy of this treatment. Julien Hubert renal group looked at a pool of 21 patients that were transplanted with eculizumab. Some are coming from a French national survey, 10 patients, and some are coming from the exhaustive literature research. And he wrote to all authors to contact them, and these authors were nice enough to provide up-to-date information on these patients. What are the data? When eculizumab is used to rescue post-transplant recurrence, you see mainly adults with a lot of previous transplantation lost to recurrence, high-risk complement abnormalities in these patients, mainly factor H, and these patients was converted from plasma exchange to eculizumab in case of resistance or in case of plasma dependence. The mean delay between the recurrence and the treatment was 30 days, and as the result, you can see that in all cases, hematological features remained to normal, and maybe more interestingly, mean serum creatinine went from 300 to 135 in all patients. When it was possible to look at the blockade of C5b9, you can see here in this patient that during recurrence you see a clear positivity of C5b9 in the glomerulus, while it is no longer the case at 1 year when the patient is on eculizumab. Interestingly, it's useful to treat the patient very early. This is the interval between atypical HUS episode and the beginning of treatment. You can see here the graft function recovery is higher here than when you wait for too long. It's not recommended to use a single dose, because when you use a single dose you have a relapse of the disease, and this relapse is not always sensitive to the treatment. It's not also a good idea to increase the interval between 2 doses, because you can see here that some patients had relapse. Of course, these were mild and responsive to eculizumab, but it's probably not a good idea to increase the interval between the 2 doses of eculizumab. What's happening when you are using this drug as a prophylaxis, mainly in children? Again, a lot of previous graft lost to recurrence, high risk genetic abnormalities, and when we are looking at the way each child received the treatment, in yellow you see the injection of eculizumab, and in some patients they received at time of transplantation also a plasma exchange. But what about the results? After a median follow-up of 14 months, you see that all patients but one had a serum creatinine of 71 micromole per liter without any recurrence in the transplant course. So that's really very interesting data in this population. Finally, a word about membranous nephropathy. You all know that we don't know exactly how is it working. Is it small complexes going directly onto the pedicels of the podocytes? Is it antibodies looking at an antigen that is present on the podocytes? Or is it a planted antigen that goes first to these pedicels and then antibodies going there secondarily? We have made some progress in this regard since a few years ago was published by Beck and colleagues a very important paper showing that this was indeed the antigen present on podocytes, and that was the target antigen. This molecule is anti-phospholipase A2 receptor, and this is the target of IgG4 in patients with membranous nephropathy. This can be measured in the serum of patients, and this is coming from a group of Paris in Tenon, where they looked at PLA2R receptors you see cellularly in some patients in recurrent membranous nephropathy or de novo membranous nephropathy. They find that these antibodies were present in half of the patients with recurrence and none in the patients in de novo. So it might be useful to monitor these antibodies after transplantation of patients with membranous nephropathy. But unfortunately, you can see that, for example, in this patient, you see high level of antibodies. is transplanted at that time, and then no antibody was detectable, but in spite of this, he recurred at that time. And you may have the other way around. Here, a patient that is transplanted without antibodies, he recurs, and you can see that there he has antibodies. So far, it cannot be used as such as a biomarker, but we have to further accumulate data on this matter. To conclude, post-transplant disease recurrence is a significant cause of graft loss, especially in younger recipients. Modern immunosuppression has not changed these figures in the last decade. Biomarkers such as SUPAR and anti-PLA2R antibodies needs to be evaluated further, and we have currently very promising therapeutical perspectives, combined IVIG cyclosporine, hydrosteroids, and plasmid change in the treatment of FSGS, eculizumab in the treatment of atypical HUS, and maybe also antiphospholipid syndrome, and anti-CD20 in the treatment of membranous nephropathy. I would like finally to thank you for your attention, and this guy because he worked on membranous nephropathy, and Rebecca and Julien Joubert because they worked on